Hello, everybody, and welcome officially to the third session of the International Deprescribing Journal Club, hosted by the United States Deprescribing Research Network. This International Deprescribing Journal Club is the product of a collaboration between the Australian Deprescribing Network, the US Deprescribing Research Network, the Network of European Researchers in Deprescribing, the European Society of Clinical Pharmacy, and the Canadian Medication Appropriateness and Deprescribing Network. To start, we do want to thank all of these groups for their efforts in collaborating with us to plan this session. I am the moderator today. My name is Jim Silvius. I'm a professor and geriatrician here in Calgary, Alberta. I'm also a senior medical director with our local health authority, which is in fact the regional health authority for the entire province. And I'm the executive director of the Canadian Medication Appropriateness and Deprescribing Network. As it says, I'm delighted to be here today and to be able to moderate this session. The agenda for today, we'll have a brief welcome and introduction of the presenter. We'll then have the presentation, which will take approximately 30 minutes or so. We'll then have time for a Q&A period, a question and answer period, and then we will wrap up. And the wrap-up will include a satisfaction survey. The reason that we do the survey is because it's important for us to know if this session met your expectations and how we can improve upon it in the future. So briefly, why we're here today, all these groups of researchers and clinicians from different continents thought we needed ways to connect and discuss ideas, recent deprescribing publications, and complex clinical cases. This is how the Journal Club was born. Our goal is to foster connections and collaborations, as well as to share the latest research about deprescribing. Just before we get started, a bit of housekeeping. To help us ensure good quality for the audio during the speaker's presentation, please keep your microphones muted. Because not everyone is able to attend live, especially those living in different time zones, we are recording these sessions. Please take note that this recording will be posted on the CADeN YouTube channel later today and will become available for people to see. The information on the recording will also be posted on deprescribingnetwork.ca Journal Club, so the address on your screen. And you can also consult this webpage to view all previous Journal Club sessions. Now, oh, wait a minute. I obviously forgot that one. Okay. During today's presentation, you may have questions. We encourage you to have them. That's why we're here. If you have questions during the presentation, we invite you to use the chat function to enter your question. We will keep track of them. During the question and answer period, you may want to share thoughts or questions verbally. And if so, we kindly ask that you raise your hand. With that, I'd like to introduce our speaker for today. Dr. Ariel Green is Associate Professor of Medicine at the Johns Hopkins University School of Medicine. Her areas of clinical expertise include geriatric medicine and general internal medicine, with a particular interest in reducing use of potentially harmful medications in older adults. Her research, supported by the National Institute on Aging, is evaluating the impact on patient and caregiver outcomes of pragmatic interventions to optimize prescribing for older adults with dementia in primary care. Dr. Green is a core faculty member of the Johns Hopkins Bloomberg School of Public Health Center for Drug Safety and Effectiveness. She is also a member of the American Geriatric Society Clinical Practice and Models of Care Committee. She co-authored the American Geriatric Society's recommendations for choosing wisely, a national initiative that aims to promote conversations between patients and doctors about avoiding unhelpful medical tests and treatments. Welcome, Dr. Green, and we look forward to your presentation.
Thank you so much. Let me just share my screen. Okay, so can you all see my slides?
Yes, we can. Thank you.
Okay, great. So good morning or good afternoon, depending on where you are. I am truly honored and delighted to be here and present at this session hosted by the US Deprescribing Research Network. And I'll be presenting on our pilot study of pharmacist-led telehealth deprescribing for people with dementia in primary care. I have no disclosures. And so my objectives for this session are that at the end of the session, you'll understand the rationale and design of aligning medications with what matters most. You'll appreciate the successes and challenges encountered in implementing a prescribing intervention for people with dementia in the primary care setting. And you'll be able to describe our key learnings from this pilot and how they are informing plans for a larger embedded pragmatic clinical trial. So this pilot study was a collaboration between our team at Johns Hopkins in Baltimore, Maryland, and our wonderful colleagues at Kaiser Permanente Institute for Health Research in Colorado. And although I'm presenting today, this study truly would not have been possible without the heroic efforts of all of the people listed on this slide. So to give you a bit of background, I don't need to spend much time telling this audience that community dwelling people living with dementia are exposed to high rates of inappropriate polypharmacy in situations in which potential harms of medications outweigh their potential benefits, medications are unnecessary or poorly aligned with patients' or care partners' goals of care. And as Josh Niznik and colleagues recently wrote so eloquently, for patients with dementia in particular, goals of care may shift as dementia progresses, such that medications focused on comfort may become more important for some people than as compared with medications focused on life prolongation or maintenance of function. And so deprescribing strategies which align with patient and care partner goals are needed. There has been increasing interest in deprescribing interventions among community dwelling older adults. And we know from systematic reviews that some of the more effective interventions to date have been patient-centered and multidisciplinary, and have often involved comprehensive medication review, in many cases carried out by pharmacists, or direct-to-consumer educational materials. However, important knowledge gaps remain. So few of these interventions addressed care partner decisional needs. And we know that, especially for patients living with dementia, care partners face a lot of unique decisional needs and conflicts. In addition, the best approach to integrate deprescribing into existing primary care workflows is still uncertain. We know from our team's qualitative research, as well as work by others, that there are some barriers to deprescribing in the primary care setting. So for one thing, primary care clinicians have told us that they are hampered by limited evidence on when and how to deprescribe. It's also challenging for them to coordinate with other prescribers when patients are seeing multiple clinicians, often in different healthcare systems. Conversations about deprescribing can be difficult to have with patients and families. For example, how to explain that you're recommending stopping a statin for primary prevention of cardiovascular disease without sounding like a withdrawal of care. And finally, a big challenge is the tremendous time pressure facing primary care clinicians. And so this was a quote from a primary care provider in one of our qualitative studies who said, not only do I have to look at the evidence, but I also have to look at the whole person. I can't just focus on the guidelines. And so our thought was that pharmacists and primary care providers working together as interdisciplinary teams can leverage time more effectively, and pharmacists can provide evidence-based, individualized deprescribing recommendations to PCPs. So we designed Align with extensive stakeholder engagement throughout all phases of study design and implementation. So in the planning and design phase, we did several qualitative studies involving patients, care partners, and primary care clinicians. We did a national survey to assess older adults' preferences regarding deprescribing communication, or how primary care providers can justify or explain deprescribing recommendations. And we consulted with pharmacists and clinic medical directors and other health system leaders. During the implementation phase, we obtained informal feedback from the pharmacists who were implementing the intervention and had them fill out implementation questionnaires. And we also recorded each of the intervention visits, which I'll tell you more about in a little bit. And then finally, in preparation for the full RCT, we consulted with care partners and clinicians, again, as well as pharmacists and health system leaders. And so just briefly, these are some of the key learnings from our qualitative research that informed intervention development. So we learned of the importance of framing deprescribing as a routine and positive step to preserve health, to avoid it sounding like a withdrawal of care. And so, for example, here's a care partner who said, the doctor would say, at your age, you probably have lived a good long life, but I didn't like that because I would like to preserve her forever. We also learned of the importance of respecting the care partner's lived experience, particularly for care partners of people with dementia. And so here's a care partner who said, I fought for the Ativan because I know what we go through. I hear what they're saying, but I would rather take that chance. We learned that patients and care partners and primary care providers have a lot of trust in pharmacists. One PCP told us, we rely on pharmacists. We need their help in sorting through it all or giving us guidance on the best plan to wean a medication. And then finally, we learned of the value of priming patients and care partners with deprescribing educational materials. So for example, one care partner said the brochure is a great conversation starter for older adults who might not be accustomed to a time when you did not question the doctor. And so putting together all of this feedback, we designed ALIGN as a multi-component intervention. The first phase involved patient and care partner education with an educational brochure that we mailed to their home, and I'll show you the brochure in a minute. Next, the dyad had a telehealth, either phone or video visit with a pharmacist who used a script that we designed together with pharmacists to elicit their goals of care and what they found most helpful or burdensome about their medications. And then finally, the pharmacist developed their individualized recommendations to optimize the patient's medicines, and they reached out to the PCP through the electronic medical record to deliver their assessment and their recommendations. And once they had the PCP's approval, they called the patient and family back and began to implement the changes. And so this is the brochure that we mailed to patients and care partners ahead of the pharmacist visit. This incorporated a lot of the concepts and phrases that we had learned from our qualitative research, and our survey research really resonated with patients and care partners. And this was designed to introduce them to the idea of working with a pharmacist who works closely with their primary care doctor to review their medicines and determine if there's anything that they can safely stop. These were the domains that the pharmacist addressed during the telehealth visit. So first, they did a thorough medication reconciliation with the patient and care partner. Then they asked questions to assess their functional status, their most challenging or bothersome symptoms, to elicit any potential adverse effects of medications, to determine their understanding of their health trajectory, and to ask about their healthcare goals, particularly in the next 6 months to a year. Then they asked if their goals were more focused on comfort versus prevention. And finally, they asked about their perceptions of their current medicines, what they found, which ones they found most helpful versus bothersome. So this is an excerpt from the pharmacist script or template. So they asked, what are your most important goals for the patient's healthcare for the next 6 months to a year? Some people say they want to do everything they can to prevent future illness, such as heart attacks and strokes, even if it means taking additional medicines or experiencing side effects, while others say they want to focus more on comfort than prevention of things that may happen down the road. In general, which would you say is more important for you right now? And finally, if we changed your medicines, what do you wish we could address or help with? And so ALIGN was a 2-arm randomized pilot feasibility study. Dyads were randomized either to an intervention group that had the pharmacist visit immediately after receiving the brochure, or to a waitlist control group that received the pharmacist visit 3 months after the brochure. So we screened about close to 500 patients across both sites, Hopkins and Kaiser Permanente. We actually had to exclude 428. 174 of them were ineligible after screening. The main reasons for ineligibility were that patients did not have a care partner or declined to name a care partner. There were also some who were living in a long-term care facility or had enrolled in hospice, which was something that our pragmatic screening through the electronic medical record was not able to determine. And so ultimately, we randomized 69 dyads. And this slide is just to show that the same percentage, 80% of those randomized, received the intervention in both groups. So this table shows the baseline characteristics of the patients who participated in the pilot. So you can see that the mean age was about 80 in the intervention group and 82 in the waitlist control group. This was a fairly diverse sample in terms of race and ethnicity, and the total number of medications at baseline in both groups was about 13. And these are some of the feasibility and acceptability data. These are reported for all 55 patients who completed the intervention because the control group also received the intervention after 3 months. And so an important measure was the amount of time that the pharmacist spent per patient on the intervention. And so we found that 71% of the intervention visits involved 20 minutes or less in indirect time. So that's chart review or documentation. However, the vast majority, 93%, took more than 20 minutes in direct time. So that's on the phone or face-to-face with the patient or care partner. We also found that 62% of interventions required additional follow-up calls beyond the 2 that were required in the protocol. And so these were typically additional calls by the pharmacist to make sure that the patient was doing okay with tapering, not experiencing any symptoms, that they understood the recommendations and the instructions. We found that PCPs had a high level of engagement with the intervention. So 82% responded to the pharmacist's electronic medical record message on the first outreach, and 85% accepted the pharmacist's recommendations. And then in terms of preliminary efficacy, so we found that 81% of patients in the intervention group had at least one medication stopped by 3 months, and 50% in the control group had at least one medication stopped. However, interestingly, we also found that 78% of patients in the intervention group had at least one medication added by 3 months, and 43% in the control group had at least one medication added. Overall, these changes were associated with a modest decrease in the total medication count at 3 months in both groups, as you can see here. And then we had another measure, the medication regimen complexity index, which takes into account the dosage forms, the frequencies, and any additional instructions for use, such as take with a meal or break or crush a tablet. And we found that in the intervention group, that decreased or improved, while it increased at 3 months in the control group. We also categorized each of the pharmacist's recommendations. And so from this, we found that 42% of their recommendations were true deprescribing. So they were recommending to stop a medication or decrease the dose or frequency. For example, here where the pharmacist was saying, recommending to discontinue mirtazapine because the patient was sleeping too much. Another 19% of the recommendations were additional steps related to deprescribing, such as start checking daily blood pressures this week to determine if the blood pressure medications can be adjusted. 17% of recommendations were designed to make the regimen easier or safer, but did not necessarily mean deprescribing. For example, replacing 2 medications with 1 medication that has the same effect. And finally, 12% of the recommendations were to actually start a new medication or increase the dose or frequency. Frequently, these were medications designed to provide to alleviate bothersome symptoms or for preventive or functional goals, such as start alendronate. And as I mentioned earlier, we recorded the pharmacist visits, and this provided a lot of rich information about how deprescribing, what actually happens during deprescribing, and how the goals elicitation process with the pharmacist drove their optimization recommendations. So one thing we learned from the recordings was that patients and care partners really prioritized reducing or eliminating symptoms. And so these are a couple of representative quotes. One of the care partners said, "If we could get her less tired, then I think she would feel better and she'd want to do more." And another said, "I'm hoping that the walking and the balance improves so she could be more independent and get around on her own." We also saw that patients and care partners seemed to really understand in many cases that medications have trade-offs, and this understanding often opened the door to deprescribing conversations. So for example, one care partner said, "I want her to be comfortable, but I don't want her to have any more side effects." Another said he stopped taking the oxycodone, which really helped because he was much more cogent. And a third said, "You've got to take this to make you healthy, but if the side effects are killing me, whittle it back." We, as I mentioned earlier, we also obtained feedback from patients and care partners who had participated in the pilot. And these are some examples. So one care partner said it was empowering to know that there are issues out there that can be discussed, that you should discuss. Another said it helped, the pharmacist visit helped to identify issues we were having with certain medicines, and it helped us form short-term goals. A third care partner said the brochure itself did not make me want to stop or change medicine, but the further conversations with the pharmacist were far more valuable. And finally, the pharmacist acted as an intermediary with the doctor. Speaking to the pharmacist opened the door to talk to the doctor about medications. We also, as I mentioned, we obtained feedback from the intervention pharmacists. And here are some examples. So one pharmacist said, "Many of these patients are on so many medicines and I don't know them. So it has taken me 2 to 3 hours per patient." So this really shows that the outcome measure that we captured from their documentation didn't begin in some cases to truly capture the amount of time they were taking. So a lot of that was just not documented. And they said phone calls, chart reviews, follow-up phone calls, it just takes a lot of time. They also said any adjustments have to be made in partnership with the specialist, which is time consuming in terms of coordination. And finally, I was pleased with how appreciative the care partners were. I think they appreciated having someone ask what's important to them and what their concerns are. And so to wrap things up, so we had a number of successes with this pilot. So first of all, we learned that pharmacist-led telehealth deprescribing was feasible and acceptable. We were able to recruit a diverse study population that was reflective of the underlying population. Once enrolled, most dyads completed the intervention. Feedback from care partners was largely positive, and PCPs readily engaged and agreed with most recommendations. We also encountered some challenges. So first of all, recruitment required significant time for staff. So although this was designed as a pragmatic trial, many patients were ineligible due to the lack of a care partner, which is a challenge for pragmatic trials for patients with dementia. And many opted out, which I think suggests the importance of really normalizing deprescribing and making it a routine part of care. In addition, although this was designed to be pragmatic and to integrate into existing workflows, it was complex and time-consuming for pharmacists. So the visit length was near pharmacists' typical allotted time per patient, or in some cases exceeded it, and multiple follow-up calls with patients and families or specialists were often required. So the key lessons that we learned For one, are that eliciting care partner goals and priorities did not always lead to deprescribing. So as you saw earlier, medications were sometimes started or increased, and those often included things to support function or alleviate symptoms, such as pain medicines, cholinesterase inhibitors, or bisphosphonates. And this suggests that deprescribing interventions for people with dementia should be viewed as an opportunity to optimize goal concordant care rather than simply trying to increase the number of medications. We also saw that 19% of recommendations involved additional steps that needed to be completed before deprescribing, such as checking blood pressure, drawing labs. And we also saw that pharmacists often had additional interactions with dyads or with specialists beyond the required 2 visits. And this illustrates that deprescribing interventions need to develop workflows to accommodate this complexity, and outcome measurement should allow time for these additional steps to occur. Finally, we learned that deprescribing conversations are really important. So while there's an important role for very low-touch pragmatic interventions in deprescribing, we also saw that patients and care partners had a lot of needs that may be difficult to address with low-touch interventions and really benefited from the conversation with the pharmacist. This goals elicitation process uncovered a lot of these needs and priorities. And that's reflected by the fact that although the protocol encouraged pharmacists to develop up to 3 recommendations, they made an average of 5 per patient. So in terms of next steps, so we are currently preparing for a full-scale stage 4 effectiveness trial of Align across about 24 clinics in Baltimore. And this was recently funded by the NIA Impact Collaboratory as a demonstration project. So we're excited to hopefully start recruiting patients soon. We're also working to refine the pharmacist training materials and streamline the script for the telehealth visit with an even greater focus on prioritizing symptoms and discussing trade-offs. And finally, we're working with the health system on how we can normalize deprescribing and during the recruitment phase and make it more of a routine part of primary care. So we're trying to mirror approaches that health systems use to embed annual wellness visits or things like advanced care planning in routine care delivery. And so with that, I just wanted to end with a couple of questions for to prompt the discussion. So one question that I have is, how can we assess whether medications are truly consistent with patient and care partner goals of care? And a second question is, how can we address challenging symptoms of dementia as part of a deprescribing intervention? And so with that, I am really excited to hear the discussion and to take your questions and feedback.
Great. Thank you so much, Dr. Green, for this great presentation. I think there are some interesting takeaways from it. As a geriatrician as well, complexity is all I see in this space. And, you know, it's interesting that you essentially identified exactly the same thing. You know, these aren't the people who get put on 2 things and it's easy to deal with. These are the folks that really do have a whole multitude of issues that we have to try to balance. And it's critical that we actually understand the goals of the individual and their care partners. The key takeaway, believe it or not, that I took from what you've said so far was the comment about speaking to the pharmacist opened the door to talk to the physician. And, you know, we don't often, certainly in my practice anyway, we have pharmacists associated with the clinic. We don't often talk to the community pharmacists, but there are times when I do. And I find that if you actually have the conversation with them and they're on board with what you want to do, it can be very helpful because it's somebody that the patient trusts or the caregiver trusts, and it allows more conversation and more ability to be concordant in what we're trying to do. And I think that's a critical piece. I did want to ask a question. I noticed there's no questions in the chat yet. I do want to remind people to put your questions in the chat. There's one coming, good. Or raise your hand if you have a question. But the question I had was, The slide about adding medications, the pharmacist recommendation, 12% were around adding. And you had made the comment earlier about the number of, or the proportion of medications that got added. And I wondered whether the additional medications were largely driven by that 12% that were recommended by the pharmacist, or was it something entirely different?
That's a great question. And something that I think we need to go back and look at even more closely. I do think that a lot of them were medications that the pharmacist recommended adding. So as I mentioned, the things, that they elicited in the conversation were, for, treating pain, or they elicited that the care partner, actually and the patient were interested in prevention. And so, or, they were really concerned about preventing further memory loss. And so, the cholinesterase inhibitor, for example. That being said, there were medications added also in the control group before they met with the pharmacist. And so there were, of course, some medications added that were not recommended by the pharmacist, I think, as well.
Right, of course. I'm going to go to the floor first. We'll not lose the questions in the chat. Mike?
Thanks, Jim, and Ariel, terrific talk, really interesting. I've always struggled with studies like this about thinking what outcomes to measure that are going to be meaningful to stakeholders, including health systems who would fund this, particularly because when we're looking about deprescribing multiple medications, for one patient, it might decrease burden. For another patient, it might improve symptom control. For another patient, it might do nothing. And so, but when we think about having to select a limited number of outcome measures that we're hoping to change over the entire population, how do you think about that and what outcome measures we should be measuring in such sort of a multifaceted intervention with many potential areas that it might improve?
Yeah, that's my question too. That's really hard. So I think, it's a combination of measuring things like, outcomes that are important to patients that medications can affect. So things like falls and hospitalizations and symptoms. But I also think, measures of, so in the full trial, we're doing a measure of shared decision-making, the Collaborate scale. And so I think that's an outcome that's important to patients and families, and increasingly, important to health systems as well. And I'm hoping that gets at the idea that it's not just about the number of medicines or the complexity of the regimen, which was something we tried to measure in the pilot. And we found that often patients will take a more complex regimen if it means better addressing their pain, for example. So I think, as you said, like stopping a medicine may be helpful for one patient, but that same medicine may really help another patient with challenging symptoms. So I think looking at which medicines they're on or the number of medicines may be hard, but I think some of those distal outcomes, which are also hard because so many different things affect them. But I think some of those distal outcomes are important. And then also, all of those reasons are why I think some measure of shared decision-making, or how informed the decisions about medications are, is important.
I'm going to turn to the chat. The first question in the chat is, discontinuing a long-term benzo is always very difficult. Any tips on how to tackle that issue?
So I think from our research, what we've really learned is, again, framing it as a positive step. So, a preventive step. So, it's kind of like wearing your seatbelt. You may not have had a car accident yet, but, we really know that seatbelts or stopping benzos help prevent a lot of, really harmful outcomes. So framing it as a positive, making it routine. So, we always take every opportunity after a hospitalization, after an ER visit, every year to go over medicines and identify anything that, may be potentially risky. And then I think, just for the individual prescriber, if you have a pharmacist that you can work with who's embedded in your clinic, for example, I've just found it tremendously helpful to talk with them about actual, concrete tapering recommendations.
The next one, in regard to your first discussion question, would applying the what matters from age-friendly 4Ms address this?
Yeah, I mean, I do think that that's kind of what we were trying to do here. There's, to my knowledge, no, standardized measurement outcome measure of the 4Ms. But that would be great if there were a way to do that in some sort of standardized way.
Next, in the full-scale effectiveness trial, are you planning to assess impact on patient quality of life or care partner burden?
So we are not, unfortunately, again, because this, so the Impact Laboratory funds and tries to foster pragmatic trials. So outcomes are typically things that you can, assess from the EMR, for example. So we're really challenged in terms of assessing patient and care partner reported outcome measures that aren't already being collected, and by and large, they're not already being collected. So the only, we're trying to get at that. I think, well, this is kind of a roundabout thing, but like trying to identify how many medications are added in addition to stopped, I think is, some of that potentially, because, medications may be added as part of trying to better align with goals. And then we are doing the Collaborate measure, which is a measure of shared decision-making, as I mentioned, which is just 3 items. So that could, part of what we're testing in the demonstration project is whether that would be something that health systems could readily administer, like through a patient portal or in a text message or something after a visit, like they do other patient experience questionnaires.
Next, where can we find more information on stopping levothyroxine? For example, would it be better to taper off this medication?
Yeah, so that is my understanding from talking with pharmacists and endocrinologists is that is an area of ongoing research. So I would say talk with your pharmacists again about that one.
Next, what is the best way to get prescribers on board with deprescribing? What can be a factor that should be covered with prescribers?
Yeah, that's a great question. So, what we found both in the qualitative research and in this pilot is that primary care providers at least are really on board with deprescribing, and they know, they want to do more of it, but they're really challenged by, as I mentioned, the time pressures, lack of evidence in many cases. And so I think interventions that provide them with continuing to provide educational materials and have them be sort of as concrete as possible. So actual language, tips for how to bring up deprescribing of certain medicines or medication classes. And then I think, anything that can make it easier for them. And so that's why we tried this multidisciplinary approach with the pharmacist who can sort of provide them with that evidence. And you saw in that one example, like with the levothyroxine, that's what the PCPs really appreciated, I think, is that the pharmacist was actually handing them, here's the evidence, and here's why I'm making this recommendation.
I'm going to skip a question and come back because the next one is related to what you just said. So the next question is, if thyroid medication is stopped, will you still want lab drawn at a certain period?
Yeah, so I think, and again, I'm not an expert in thyroid medicine, but as you saw in that example, the pharmacist recommended checking again 8 weeks after stopping it. So they recommended it in a patient whose baseline TSH was only minimally elevated before they started the medicine. And they pointed out to the PCP that in older adults, we actually it's better to tolerate. TSH may be higher anyway. It's better to tolerate a little bit of a higher TSH, and so they recommended checking it at 8 weeks. And then if it was under 10, they said, that's good. You don't need to continue checking. You don't need to continue giving thyroid replacement.
Yeah, I would agree with you, unless, of course, they become symptomatic down the road, which then obviously you're dealing with something different or a new situation. Going back, I'm curious about your pharmacist training. Have you looked at finding BCGP pharmacists or use the training so that pharmacists who receive it can sit for the BCGP? As a pharmacy educator, having the board certification really enhances the ability of the pharmacist to participate in this.
So I'm not familiar with the abbreviation. Is that geriatric training for pharmacists?
Yeah. Hi, Ariel. It's Bob Waller. I asked the question. It's board certified geriatric pharmacist. It does, elevate their abilities.
So that's really interesting, and something that I think the demonstration project that we're gearing up for is really going to tell us a lot about. So in the pilot, the implementation pharmacists were both geriatric trained, and that did help a lot, I think, just in how they talked with patients and families, and their knowledge. So in the demonstration project, not all the pharmacists will have that. Most of them won't. And so we're trying to kind of, give them a very brief PowerPoint training, and then also a laminated card that sort of, hits the high points of kind of some principles about deprescribing for older adults. But I think we'll learn a lot about whether, the challenges for people who don't have that geriatric training.
Sorry, one suggestion on a follow-up to that.
Yes, please.
That might be an outcome to look at, is the effectiveness between board certified and non.
Yeah, that's a great point. Thank you for that.
In the United States, we are overwhelmed by media drug advertising. Are there reimbursement plans to incentivize pharmacists to help with deprescribing within or outside of the U.S.?
So this may actually be better answered by a pharmacist than me. I know there's, part of the reason that we hope an intervention like this might be scalable is that there's increasing interest. And I think some, in terms of incentivizing it financially as well, there's increasing interest in having pharmacists work as part of multidisciplinary teams in primary care clinics, and with part of what they do being deprescribing, but specifically to incentivize deprescribing beyond that, I'm not totally aware. I don't think so, but I don't know if anyone else can say more.
And does anybody have a comment on that?
Yeah, the best I can say is that, I know within our group and others, we're researching it to see, is there a way that there's reimbursement? There's incident to billing codes that can be used, but I don't know of anything specific for incentivizing and deprescribing. It would be lovely, but not that I know of.
If I can add, we could mention here in Canada, reimbursements for pharmacist activities are provincial, and we did launch a program with a province in the East, Newfoundland and Labrador, Safer-Meds-NL, which included reimbursement for deprescribing activities, targeting proton pump inhibitors, and sedative hypnotics. So publication to come soon. Be on the lookout for it. But there was, in this case, some reimbursement for these activities to be conducted by community pharmacists.
Great. We're going to run out of time here. I see your hands up, Cheryl. Just one sec. We also have a comment. We've had incentives in the UK for providing structured medication reviews in primary care rather than deprescribing per se, just in response. Cheryl, last question to you.
I wanted more to but respond to the issue of incentives and to some of the work that has been done in the US and work I've been involved with in Canada is the cost, if you just look at the cost of medications and what the pharmacy makes in terms of profit, deprescribing is always a financial loss. No matter, even if we reimburse, when you look at chronic medications, long-term use of medications, there is always a loss of profit. And so I think that's always something that has to factor in when we're talking about community pharmacies. It's a perverse incentive policy-wise that it pays more to keep them on inappropriate or unnecessary medications.
Thanks. Now, you did put a question in the chat. Do you want to very quickly ask the question, and then we'll need to move on?
Yeah, I know this is not a part of one of your research objectives, but I'm wondering, because you were involved as an educator as well, if you have any comments about how this might connect to educational initiatives you're trying to champion at your institution.
Yeah, so I'm not actually an educator. I'm a clinician researcher, but I do think, just ongoing education for clinicians, not only PCPs, but also, in specialties about deprescribing, the importance of deprescribing, how to talk with patients and families about it, how to think through some of these challenging decisions. I think that would be really useful. I think some of there's a comment in I think it was your comment actually about bringing students together to change how collaboration and communication. I mean, I think that would be fantastic, like more initiatives to bring like pharmacy students, med students, residents, to bring trainees together so that they actually come out of training already thinking about like collaborating with each other and not just thinking about guidelines and evidence for when to prescribe, but also when to deprescribe.
Great. Thank you very much. Again, thank you for the great talk. Very interesting to see some of the work that's going on. If we go back to the slides, because we're losing people here, I know. Just a shameless plug for the next session, which will be hosted by CADeN. The link has now been put in the chat to register for the next session, which will be on December 6th at 11 o'clock in the morning Eastern Standard Time. And it is on a proposed curricular framework for an interprofessional approach to deprescribing, and we will have 3 speakers, including Cheryl, who you've just heard the question from. The next slide, if we can move to the feedback. We'll launch a poll to know if this session meets your needs. If we can have the poll come up, please. We want to know how satisfied you are, which is the first question. There's 3, I think. The second, what's the likelihood of you attending another journal club session? And the third is on types of content you're most interested in seeing. So if you can answer those questions for us, please. And I see we're getting some responses. You may have more questions for our speaker or comments that aren't shareable with the Zoom multiple answer poll. You may also want to be involved with the planning of future journal club sessions or want to suggest a future topic. If so, You can write to us at the email that's on the screen, info@CADEN-ReCAD.ca. Thank you once again for attending this session, and we hope to see you at our next session. And as the results are coming up, I also want to thank the organizing committee. You can see folks identified there. The session wouldn't have been possible without the participation of the different groups. And thank you to each and every one of our members for their help. A special thank you to Raha from the USDeN, who has been essential to the organization of this particular session. And with that, once you have provided your feedback, I think we have all the feedback participants that we have left have responded. So thank you again, everybody, and enjoy the rest of your day.